Welcome to the Deep Dive. This is where we try to take some really complex, sometimes contradictory research.
And boil it down.
Exactly. Boil it down into something, actionable knowledge for you.
And today's topic is, well, it's a perfect example of that. We're looking at how fast technology is moving, sometimes faster than clinical guidelines can keep up.
That's right. We're wading into prostate cancer staging today.
Specifically, we're tackling a big disagreement, a real split in international guidelines.
It's all about PSMA PET, that's prostate-specific membrane antigen positron emission tomography. Quite a mouthful.
It is.
But our focus isn't on high-risk cancer, where everyone pretty much agrees it's useful.
No, the real confusion, the mission for this deep dive is its role for men newly diagnosed with intermediate-risk prostate cancer, PCA.
Yeah, and we've dug through the guidelines, the sources reviewing recommendations from, 7 major international organizations?
That's right. We looked at the EAU, AUA, NCCN, MIC over in the UK, CUA from Canada, ASCO, and the SMMI, the nuclear medicine folks,
Yeah.
a real cross-section.
And the first thing that jumps out is, it's not just a minor disagreement.
No, it's a genuine lack of consensus, a real schism, as you said. The tech, PSMA, PET, everyone agrees it's better imaging than the older stuff.
Right, it sees more.
But the big question is, for these intermediate risk patients, does seeing more actually change things in a way that's necessary and, cost effective?
That's the heart of it. Because for high-risk PCA, the guidelines are strong. Use PSMA PPE, but drop down to intermediate risk.
Yeah, it all gets murky. Recommendations become weak, conditional. Often they're just based on what experts think, not solid, broad evidence.
So we've got this clearly superior tool, but the medical world just can't seem to agree on exactly when or if to use it for this large group of men. We're going to unpack why today.
Okay, so let's start with the tech itself. Why is PSMA PET considered such a game changer?
Well, it comes down to biology. It uses a radioactive tracer that's designed to find and stick to something called prostate-specific membrane antigen, PSMA.
And that's a protein found on prostate cancer cells. Exactly. But not just found, it's massively overexpressed, meaning there's way, way more of it on the surface of most prostate cancer cells compared to normal tissue.
So you inject the tracer.
Right. It travels through the body, and it basically hunts for cells with lots of PSMA. Wherever the cancer has spread, maybe tiny lymph nodes, maybe bone spots, maybe other organs, the tracer locks on.
And the PET scanner sees that accumulation. It lights up.
Precisely. It lights up because of that high concentration of the tracer. And that gives you this incredibly sensitive picture, with resolution that the older scans, like CT and bone scans, just couldn't dream of matching.
Makes sense. Better visibility.
Much better.
And wasn't there one particular study that really kicked off its widespread adoption?
Oh, absolutely. You're talking about the PSMA trial. Came out of Australia. That study was foundational.
ANZ-CTR 1261700000535 for those tracking. What did it show?
It wasn't subtle, as you said earlier. It was a direct head-to-head comparison. PSMA PET versus the old standard.
Which was CT plus a bone scan.
Right. Two separate scans. CT for soft tissues and lymph nodes. Bone scintigraphy for the skeleton. The PSMA trial just unequivocally showed PSMA PET was more accurate.
More accurate in what way? Finding MITs.
Yes, finding metastases, both nodal and distant. Yeah. It also had fewer ambiguous or equivocal results. You know those scans where the report says, maybe something, maybe nothing?
Yeah, those aren't helpful.
Exactly. PSMA PET gave clearer answers, and bonus, it was often just one scan instead of two. Simplified the whole staging process.
Okay, so that superior accuracy, let's put some numbers on it. The sources we looked at, like that Mazone meta-analysis, they highlight a pretty big difference in detection rates depending on risk level.
Huge difference. And this is critical to the whole debate. For patients classified as high risk, PSMA PET found nodal or distant metastatic disease in about 31% of them.
Wow, nearly a third.
Yeah, think about that. Almost 1 in 3 high-risk guys had disease spread, often hidden, that conventional scans missed. That finding immediately changes management, right? It solidifies why it's standard for high risk.
Okay, but now shift to our main focus. Intermediate risk PCA. What happens to that detection rate?
It drops significantly, down to about 15%.
15%, so cut in half.
More than half, yeah. Now look, 15% isn't zero. If you're one of those, say, 1 in 7 men in that group who does have hidden spread, finding it is life-changing. It alters your prognosis, your treatment plan, everything.
Absolutely.
But for the other 85% of intermediate risk men, the scan doesn't add new information about spread. It confirms they don't have detectable mets outside the prostate.
And that difference, that 31% versus 15%, that's the statistical battleground for the guidelines.
That's exactly it. Is it worth scanning everyone in the intermediate group, given the cost and resources,
Right.
to find that spread in 15%? Especially when the philosophy in some guidelines is leaning towards less intervention unless absolutely necessary.
It creates this immediate tension. Do you spend the money and time scanning 100 men to change management for 15?
That's the question health systems and guideline panels are wrestling with.
And you mentioned Australia earlier with the PSMA trial. They seem to have answered that question differently.
They did. It's a fascinating real-world example. Based largely on the PSMA evidence, the Australian government approved a Medicare rebate, that's their public funding item number 61563,
And that covered PSMA PET
for newly diagnosed prostate cancer patients with an ISUP grade group of 2 or higher. So that includes all intermediate risk and high-risk patients.
So essentially, funding made it the default first-line staging scan overnight.
Pretty much. It rapidly became the standard workup across the country. For Australian men, that meant faster staging, often a single, more accurate scan. It really changed practice on the ground.
But you're saying that's not typical elsewhere.
Far from it. Our sources are clear. The huge variation you see in guidelines from the US, Europe, Canada, it ties directly back to differences in funding, how readily available the scanners and tracers are.
Right, you need those cyclotrons nearby to make the tracer isotopes.
Yeah, exactly. Availability is patchy. And there are major concerns about the overall cost versus the perceived benefit, especially for that intermediate risk group where the yield is lower.
So in places where healthcare budgets are tight or the tech isn't on every street corner, that 15% detection rate might seem, well, not compelling enough for a universal mandate.
Precisely. The guidelines outside of places like Australia are often weighing that superior accuracy against very real economic constraints and access issues.
Okay, so before we get deeper into the weeds of the intermediate risk conflict, let's just solidify where everyone does agree. High-risk disease.
Yes, absolutely. On this point, there's broad, almost universal consensus. For primary staging in men diagnosed with high-risk prostate cancer, PSMA PET is the way to go.
That 31% detection rate we mentioned really seals the deal there.
It does. Finding out if the cancer has already spread is critical for high-risk patients. It determines if they're even candidates for potentially curative local treatments, like surgery or radiation, or if they need systemic therapy right away because the horse is already out of the barn, so to speak.
And which guidelines specifically support this?
Well, the EAU and NCCN, SNMMI, they all either recommend it or strongly support using PSMA PTT for primary staging in high-risk cases.
And there's that practical advantage too, right? The one-stop shop idea.
Huge advantage. The NCCN and SNMMI explicitly acknowledge that PSMA PTT works for imaging both bone metastases and soft tissue or lymph node metastases, all in one scan.
Which beats the old way.
Definitely. Conventional staging usually meant a CT scan appointment for the soft tissues and a separate bone scan appointment for the skeleton. That's 2 visits, 2 waiting periods, 2 reports to correlate.
More hassle for the patient, potentially delays.
Right. PSMA PET streamlines that whole workflow. 1 appointment, 1 detailed scan. That speeds up decision-making, which is vital when you're dealing with aggressive high-risk cancer.
Okay, solid consensus for high risk. But even here, there's a bit of a wrinkle, isn't there? A difference in how it should be used, particularly from the AUA and ASCO.
Ah, yes. The American Urological Association and the American Society of Clinical Oncology, they introduce a note of caution, even for the high-risk group.
They don't recommend it first line.
Not quite. Their guidelines are more conservative. They essentially say, okay, PSMA PPT is useful, but only after you've already done the conventional imaging, the CT and bone scan, and those scans come back negative or unclear, equivocal.
So they position it as a second-line test, a problem solver.
Exactly. Not the initial go-to staging tool, but something you use if the first round of cheaper, maybe more available imaging doesn't give you a clear answer.
But wait, if we know PSMA PT is more sensitive and specific,
Yeah.
why start with the inferior tests? That feels backward and
Yeah.
potentially costly.
It does seem counterintuitive from a pure accuracy standpoint, and that's the major criticism. Why subject a patient to less accurate scans first? If they're negative, you might miss something PSMA PT would have caught. If they're equivocal, you end up doing the PSMA PT anyway.
So you're potentially paying for 3 scans, CT, bone scan, then PSMA PET, when maybe just the PSMA PET upfront would have been better and possibly cheaper in the long run.
That's the argument many are making. It introduces delays, adds cost, potentially misses diagnoses.
Which brings us to the cost debate directly. You mentioned the Australian data suggested PSMA PET was actually cheaper compared to CT plus bone scan.
Yes, an analysis of the PROP SMA trial data in Australia found a lower direct comparative cost for PSMA PET as the initial strategy.
How much can we generalize that? Australia has a very different healthcare funding system, right? Heavily subsidized, centrally managed pricing.
That's the crucial caveat, that Australian finding hasn't necessarily been replicated everywhere. In the US and many parts of Europe, hospitals often report that the upfront cost of the PSMA radiotracer and the PET scan time itself is higher than doing a standard CT and bone scan.
So reimbursement models, tracer production costs, scanner availability, it all plays into why groups like AUA and ASCO might be hesitant.
Absolutely. Their caution likely reflects not just clinical evidence, but also the economic realities and resource constraints within their dominant healthcare systems.
Yeah.
If CT and bone scans are readily available, maybe cheaper upfront, and fully reimbursed.
Then using the more expensive, potentially harder to access PSMA PET only as a second-line tool starts to make a certain kind of administrative or economic sense, even if it's not optimal purely based on accuracy.
Precisely. The AUA and ASCO stance seems rooted in a philosophy of using the premium diagnostic only when it's highly likely to change management, or when cheaper options fail. They might argue that if a conventional scan is clearly negative, the added value of PSMA PET, even in high risk, might be small in their view.
But the counter-argument remains strong. Given the known superiority, using it first line avoids delays, potential misdiagnosis, and could even be economically sound if you factor in the cost of missing metastases or doing redundant scans.
Exactly. The data on sensitivity and specificity really challenges that conservative second-line approach and bolsters the case for PSMA PET as the preferred initial staging tool for high-risk disease wherever feasible.
Okay, let's dive headfirst into the main event. Intermediate risk prostate cancer. This is where, as you said, the consensus completely breaks down.
This is the eye of the storm, yes. Largely because that detection rate for nodal or distant mets drops to that, roughly 15% figure we discussed.
And the big question becomes, is finding spread in 15% of these men worth the cost and effort of scanning the other 85% who will have a negative scan?
That's the calculation everyone's making differently. And generally speaking, the overall trend in the guidelines is not to widely recommend routine PSMA PET for this entire group.
Why not? What's the core reasoning?
The logic is fairly straightforward. In intermediate risk disease,
Which for many intermediate risk guys is often local therapy, right? Surgery or radiation aimed at cure.
exactly. If the plan is already radical prostatectomy or definitive radiation, finding out there are no METs via PSMA PT doesn't really alter that plan for most.
But intermediate risk isn't one single category, is it? The sources often split it.
Crucial point, yes. You absolutely have to distinguish between favorable intermediate risk and unfavorable intermediate risk. The guidelines certainly do.
Okay, break that down for us. What's the difference?
Generally, favorable intermediate risk means maybe just one intermediate risk factor present, often a lower Gleason score like 3 plus 4 and 7, which is ISCP grade group 2, and lower PSA levels. These guys are closer to the low-risk category.
And unfavorable.
Unfavorable intermediate risk means they might have multiple intermediate risk factors or a higher PSA, or critically, the presence of Gleason score 4 plus 3 equals 7, which is ISC grade group 3. That pattern, grade group 3, is considered more aggressive, even though the total Gleason score is still 7.
So having Gleason 4 plus 3 instead of 3 plus 4 bumps you into unfavorable territory.
Often, yes. Or having several other risk factors pile up. These patients are closer to the high-risk end of the spectrum. And that distinction, favorable versus unfavorable, is where some guidelines draw their lines for PSMA PET.
Okay, so let's look at the guidelines that offer some support. How do they use this distinction? You mentioned the EAU.
Right, the European Association of Urology. They offer only a weak recommendation for PSMA PET, and importantly, only if it's available, and only for men with ISPP group 3.
So specifically targeting that unfavorable subgroup.
Exactly. They explicitly say not for grade group 2 or other favorable intermediate risk patients. That weak recommendation signals they see potential value there, but the evidence isn't overwhelming enough for a strong endorsement. They're reserving it for those edging towards high risk.
What about the NCCN here in the U.S.?
Similar cautious approach. The NCCN guidelines give what they call a soft recommendation. They list PSMA PET or PMRI as an option for soft tissue imaging. Again, specifically in unfavorable intermediate risk disease.
An option, not the preferred method.
Correct. It's listed as an alternative to standard CT or MRI for looking at lymph nodes. It's not given preference. So again, acknowledgement, but not a strong push.
And the Nuclear Medicine Society, SNMMI.
They're probably the clearest in drawing this line. SNMMI supports using PSMA PET for unfavorable intermediate risk, recognizing that higher risk of spread. But then they explicitly state it's rarely appropriate for favorable intermediate risk PCA.
Okay, so EU, NCCN, SNMMI, some conditional, weak, or optional support, but really only focused on that unfavorable slice of intermediate risk.
That sums it up well. They see a potential role there, but they're hesitant to apply it more broadly within the intermediate category.
Now let's turn to the opposition, the groups that are basically saying no or not recommended, the AUA, for example.
Right. The AUA's stance is quite firm. Their guidelines state that clinicians should not routinely perform even conventional imaging CT or bone scans in asymptomatic men with low and intermediate risk prostate cancer.
Wow, so if they don't even recommend the older scans routinely, they're certainly not going to jump to recommending the newer, potentially more expensive PSMA PET for this group.
Exactly. Their philosophy seems very much focused on therapeutic yield. If conventional scans are unlikely to change management for most intermediate risk men, why do them? And that logic extends even more strongly to PSMA PT. Unless there are specific symptoms or very high-risk features pushing that patient out of the typical intermediate box, they advise against routine staging scans.
And NICE in the UK, even stricter.
Yes, the National Institute for Health and Care Excellence. Their guidelines are known for rigorous cost-effectiveness analysis. Currently, they don't even mention PSMA PET for primary staging in this context.
Which usually means...
It usually means either the evidence hasn't met their threshold for cost-effectiveness yet, or perhaps the guidelines haven't been fully updated since the bulk of the PSMA PET data emerged. But regardless, their current stance is very conservative. They actively discourage routine bone scans for intermediate risk and only recommend CT scans if knowing the node or metastasis status would definitively alter the management plan.
So a very high bar for using any advanced imaging.
Extremely high, rooted in avoiding overdiagnosis, overtreatment, and managing resources carefully.
And then you have CUA and ASCO, who also just don't mention PSMA PET for intermediate risk staging.
Correct. Their silence on the issue in their intermediate risk sections is generally interpreted as non-support. If they thought it was indicated, they would likely include it, even conditionally like the NCCN.
So it really paints a picture of a divided landscape. You have a few groups tentatively dipping a toe in the water for the unfavorable subgroup, and several major players saying hold off or not recommended for intermediate risk generally.
That's the situation. And it's crucial to remember, as the sources point out, even those positive recommendations from EAU, NCCN, SNMMI are generally labeled as weak or based on expert consensus.
Not based on large randomized trials specifically focused on intermediate risk patients showing a clear benefit.
Precisely. That high-level evidence specifically for the intermediate risk cohort is still lacking or maturing. It's an area crying out for more research, and the guidelines reflect that uncertainty. They're essentially waiting for stronger data to justify broader use.
Okay, so the guidelines are hesitant, especially for routine use, but the technology is superior. Surely there are arguments for using it in intermediate risk, maybe in specific situations that go beyond just finding that 15% with METs.
Absolutely. And this is where the conversation gets really interesting, moving beyond just detecting distant spread. One of the most compelling arguments revolves around avoiding surgical morbidity.
You mean avoiding the pelvic lymph node dissection, the PLND, during surgery?
Exactly. When a man undergoes a radical prostatectomy, the surgeon needs to know if the cancer has spread to the nearby pelvic lymph nodes. The traditional way to get definitive staging information is to surgically remove those nodes, the PLND.
And you mentioned earlier that's not a minor procedure. It adds risks.
Significant risks. PLND is associated with complications like lymphocyles. Those are collections of lymph fluid that can get infected or require drainage, happening in maybe 5% to 15% of cases. Plus, risks of infection, blood clots like DVT, nerve injury. It definitely increases the morbidity of the overall operation.
So surgeons don't always do it.
Right. Because of the risks, PLND is typically reserved for patients where the calculated risk of having positive nodes is reasonably high, often using nomograms. Many intermediate risk patients fall below the typical threshold, say 5% or 10% risk, where a surgeon might choose not to do the PLND to spare the patient the outed morbidity.
Okay, so where does PSMA PET fit in here?
It offers a highly accurate, non-invasive way to assess those pelvic nodes. And the key here is its negative predictive value, or NPV.
Meaning, if the scan is negative, you can be very confident there's actually nothing there.
Exactly. Especially in patient groups with a lower baseline risk of nodal metastases, like many intermediate-risk patients. The NPV of PSMA PET is extremely high. Meta-analyses show this.
So let's say you have an intermediate risk patient. Maybe their nomogram score puts them borderline for PLND. If you do a PSMA PET scan beforehand and it comes back completely clean in the pelvis.
Then the surgeon can proceed with a prostatectomy with much higher confidence that the nodes are negative, potentially justifying the decision to omit the morbid PLND.
That sounds like a direct patient benefit, less risky surgery.
It absolutely is. It's about using the scan's sensitivity not just to find disease, but to confidently rule it out, and thereby avoid an invasive, potentially harmful procedure. This is a powerful argument for its utility that doesn't depend on finding rare distant mets.
Okay, avoiding PLND morbidity. Well, what else? You mentioned something about assessing the primary tumor itself, detecting undergrading.
Yes, this is another huge potential application, especially relevant for the growing number of men considering active surveillance or AS.
Active surveillance is an option even for some intermediate risk patients now, right? Particularly the favorable ones.
Increasingly so, yes. But a major concern with AS is the accuracy of the initial biopsy grading. A biopsy only samples tiny bits of the tumor.
So it might miss a more aggressive area?
Precisely. We know from studies looking at the whole prostate after surgery that about 23%, almost a quarter of cancers, initially graded as intermediate risk on biopsy, are actually upgraded to a higher, more aggressive grade group on the final pathology.
And if one of those undergraded guys goes on to active surveillance?
They could be delaying necessary, potentially curative treatment, thinking their cancer is less aggressive than it truly is. That's a critical risk.
So how can PSMA PET help here? It's not looking at the cells under a microscope.
No, but it's looking at the tumor's biological activity. Remember, PSMA expression often correlates with aggressiveness. Features on the PSMA PET scan of the primary tumor itself specifically, how intensely it takes up the tracer, measured as the maximum standardized uptake value or SUV max, seem to correlate with bad features.
So a really hot spot in the prostate on the scan might indicate a more aggressive cancer, regardless of what the biopsy showed.
That's the idea. A higher SUV max within the tumor has been shown to be associated with things like a higher final grade group after surgery, or extra prostatic extension, the cancer growing outside the prostate capsule.
I see. So imagine a patient classified as favorable intermediate risk, maybe ISEP grade group 2, considering AS, if their PSMA PET shows a really high SUV max in the prostate.
That could be a red flag. It might suggest they're actually in that 23% group who are undergraded. It gives you another piece of data, a non-invasive biomarker, to refine their risk assessment beyond just the biopsy result.
Helping to select patients for AS more safely.
Exactly. It could help identify men who, despite seemingly favorable biopsy results, might harbor more aggressive disease and perhaps shouldn't opt for AS. This potential is so compelling that there are ongoing clinical trials like the CONFIRM trial, the PASSPORT trial, specifically investigating how PSMA PET can be integrated into AS protocols to improve patient selection and monitoring.
So this argument isn't about staging spread at all. It's about using PSMA PET to better characterize the primary tumor's aggressiveness.
Correct. It shifts the justification away from that contested 15% metastasis detection rate and towards improving the safety and effectiveness of managing the primary disease, whether that's planning surgery or selecting for active surveillance. It potentially benefits a much larger group of intermediate risk men.
Okay, we've heard compelling arguments for PSMA PET and intermediate risk. Avoiding PLND, catching undergraded tumors for AS decisions sounds great, but there must be strong counter-arguments, reasons for the guideline hesitancy beyond just cost or the low met rate.
There are. And perhaps the most significant intellectually is the concern about something called the Will Rogers phenomenon.
The Will Rogers phenomenon. Named after the humorist, what's the connection?
It refers to a statistical quirk that happens when you introduce a much more sensitive diagnostic test for a disease. Will Rogers famously joked that when the Dust Bowl migrants, the Okies, left Oklahoma and moved to California, they raised the average intelligence level in both states.
Huh. Okay, how does that apply to cancer staging?
Think about it. PSMA PET is so sensitive it finds tiny amounts of cancer spread that were previously invisible to older scans like CT.
Sure.
Specifically, it finds tiny lymph node deposits, sometimes called molecular imaging N1 or MyN1 disease.
Okay, nodes that CT would have missed.
Right. So before PSMA PET, a patient with only MyN1 disease would have been staged as N0 nodal spread because their CT scan was clean. Their treatment and prognosis were based on being N0.
Makes sense.
Now, along comes PSMA PET. It finds that tiny MyN1 disease. So we correctly reclassify that patient as N1 nodal spread. Here's the paradox.
Yeah.
We've just moved the patients with the smallest amount of nodal disease, the healthiest N1 patients, if you will, out of the N0 group and into the N1 group.
Ah, I see. So the remaining N0 group now looks like it has better outcomes because we took away the patients who actually N1, but we didn't know it.
Exactly. The average prognosis for the N0 group improves statistically. And what happens to the N1 group?
Well, it now includes these new MyN1 patients who have a much lower disease burden than the old N1 patients, who only had nodes big enough for CT to see. So the average prognosis for the N1 group also improves statistically.
Precisely. It looks like outcomes for both the N0 group and the N1 group have gotten better, seemingly because we introduced a better test and reshuffled the patients. That's stage migration, the Will Rogers phenomenon.
So it creates this illusion of improved survival or outcomes across the board without any actual change in the disease itself or the effectiveness of treatment.
That's the statistical headache. It makes it incredibly difficult to interpret historical data or even new trial data. Are patients doing better because of a new treatment applied to these newly detected MyN1 patients, or is it just the stage migration effect making the numbers look better?
So the big concern isn't just finding the MyN1 disease, it's the uncertainty about whether finding it and treating it actually helps in the long run. Does it improve overall survival?
That is the absolute core of the caution from groups like AUA and NICE.
Mm.
Early data suggests these MyN1 patients do have worse outcomes, like decreased biochemical progression-free survival compared to true N0 patients. So finding it isn't trivial. But does escalating treatment based on finding MyN1 truly change their ultimate fate? We don't have definitive proof yet.
And escalating treatment isn't without downsides.
Not at all. Finding even tiny MyN1 disease often prompts doctors to recommend more aggressive treatment. Maybe larger radiation fields, maybe adding hormone therapy, androgen deprivation therapy, ADT, which has significant side effects, hot flashes, fatigue, loss of libido, bone density loss, potential cardiovascular issues.
So you might be subjecting patients to the toxicity of systemic therapy based on finding microscopic disease whose long-term clinical significance isn't fully established yet. The risk of overtreatment.
That's the crux of the argument against routine use, especially in the intermediate risk group, where the absolute number of patients with MyN1 might still be relatively low. Are we causing more harm than good by acting on these highly sensitive findings before we know if it makes a difference to survival?
And this ties back to the low rate of distant METs too, right?
Yes, critics bolster their argument by constantly reminding us that the rate of extrapelvic disease METs outside the pelvis, in bones or distant organs, in the intermediate risk cohort is really, really low, often cited as less than 1%.
Less than 1%.
So if you're scanning 100 intermediate risk men, the chance of finding distant disease that would radically change management from local to systemic therapy is vanishingly small. The main staging dilemma revolves around those pelvic nodes.
And M1. So the bottom line against routine use is the rate of truly game-changing distant METs is tiny, and while PSMA PET finds more pelvic nodes, MyN1, the actual long-term benefit of finding and treating that MyN1 disease hasn't been proven yet, and acting on it might lead to overtreatment and side effects, all complicated by the statistical confusion of stage migration.
That captures the essence of the resistance perfectly. It's a complex interplay of low yield for distant disease, uncertain benefit from MyN1 detection, potential for harm from treatment escalation, and the statistical fog of the Will Rogers phenomenon. #tag outro.
Wow. Okay, so this deep dive really highlights that tension, doesn't it? We have this incredibly powerful imaging technology, but adopting it isn't straightforward, especially when you move away from the high-risk slam dunk.
It really shows how clinical practice has to grapple with balancing technological capability, cost, potential harms, and the need for solid proof of benefit, especially in a disease like prostate cancer, where many men might not die of the disease.
Let's try to crystallize the key takeaways for everyone listening. What are the main points you should walk away with regarding PSMA PET in intermediate risk prostate cancer today?
Okay, 4 main things, I think.
Go for it. 1.
First, no debate about the tech itself. PSMA PET is superior imaging compared to conventional CT and bone scans. The PSMA trial proved that, and because of its high yield in high-risk disease, it's universally accepted and recommended for staging high-risk PCA. That's solid ground.
Okay. Second point.
Second, when you shift to intermediate risk PCA, the guideline consensus evaporates. It's highly fragmented. You've got weak conditional support, mostly focused only on the unfavorable subgroup, like ISB grade group 3, from bodies like the EAU, NCCN, SNMMI.
And on the other side?
On the other side, you have major players like the AUA and NICE actively discouraging routine advanced staging for this group, citing low yield, cost concerns, and lack of proven benefit that alters management decisively.
Oh.
CUA and ASCO are silent, implying non-support. Big divide.
Got it. Third key takeaway.
Third, the strongest arguments for using PSMA PET in intermediate risk actually pivot away from just finding those rare distant MECs. The real utility might lie in its non-invasive capabilities, using its high negative predictive value to potentially avoid morbid pelvic lymph node dissection during surgery.
Making surgery safer.
Right. And using its ability to assess the primary tumor's activity, like SUVmax, to help identify the 23% of men who might be undergraded on biopsy, which is critical for making safer decisions about active surveillance.
Makes sense. And the fourth point, the major hurdle.
Fourth, the biggest barrier to routine adoption beyond cost is that conceptual challenge, the Will Rogers phenomenon, or stage migration. The superior sensitivity finds more, Mayan-1 disease, which looks good on paper but statistically obscures whether finding and treating this earlier actually leads to better long-term survival. This uncertainty fuels concerns about potential overtreatment and patient harm without proven benefit.
So the evidence for its utility in those non-invasive roles, avoiding PLND, checking for undergrading, seems to be building rapidly.
It is. The sources suggest that's where the research momentum is. The guidelines will likely change eventually.
But the speed depends on tackling that Will Rogers problem.
Exactly. The community needs to figure out how to prove that acting on these sensitive findings truly translates into patients living longer or better lives. Moving beyond just, we found something, to treating what we found makes a real difference.
Which leads perfectly into our closing thought for you, the listener. Given how good PSMA PET is at finding tiny bits of cancer, the critical tension isn't if we can find it, but if we can prove that acting on it helps.
Right.
So the question to ponder is, how much evidence and what kind of evidence is needed to convince the entire medical community that escalating treatment for intermediate risk patients based on finding Mayan-1 disease offers a genuine, measurable, long-term survival advantage, one that outweighs the costs and potential harms?
It's about translating detection into validated benefit.
That challenge, bridging the gap between seeing more and proving it helps, is really the next frontier in this field. That's what needs resolving before PSMA PET becomes routine for everyone with intermediate risk prostate cancer.
Knowing versus acting wisely, as you said earlier.
Thanks for joining us for this deep dive into the complex world of PSMA PET staging. Lots to think about. We'll see you next time.